All right. Hello, everyone. It is my absolute pleasure to be here today. I have been really excited to share some of the work that we're going to cover today, and so I'm eager to hear everyone's thoughts. I am going to leave about 10 to 15 minutes for questions, but feel free, if it's okay, if you're feeling brave, to just unmute and ask along the way if something is unclear. So special thanks to all of my affiliations, Computation Precision Health, electrical engineering and computer science, and Berkeley AI research. So, as everyone on this call probably knows, as we deploy more algorithms in healthcare settings, we are starting to find examples of almost egregious examples of algorithmic bias. So, although algorithms are often inscrutable, we are getting a bit more insight into the ways that bias may manifest. As one example, dermatology datasets that are used to train deep learning algorithms that have shown, above human performance. These, in fact, are actually trained primarily on data from fair-skinned patients. And this can then result in poor performance on darker-skinned patients who are not represented in the data sample. And in another example on the right, researchers have found that care management programs predicting a patient's health need for the year that, in fact, were trained on health cost. And in fact, that those algorithms could result in a biased amount of enrollment for patients in care management programs. So this is extra support from clinical staff and follow-ups. So overall, this racial bias, because it's trained on cost and not health need, can result in disparate impact on patient subpopulations. As an example from my own work, we looked at chest X-ray algorithms. So these are huge data sets. It's not that certain groups are being underrepresented in this case. There's hundreds of thousands of people in the data set, any group you could think of, all in the data set. And in fact, we found even then that there is underdiagnosis for patients who are underserved. So particularly Black women are receiving worse diagnoses, and particularly they're being told there's nothing wrong with you, you can go home, but in fact, it's a false negative. So this is underdiagnosis in that respect. My whole research agenda, my research lab focuses us on questions of health equity and fairness. When we bring those questions into the picture, we start to realize that more and more technical and data challenges will arise. This is because healthcare, it's not going. There we go. Healthcare, as it's currently practiced, is not equitable. Black women, as in one example, Black women in New York City have worse rates for maternal morbidities, even after adjusting for socioeconomic status. Maternal health, keep that in mind. We'll talk about that in a second. The data that we collect may also, in fact, be skewed as well. Oh, I don't know why. Okay. In genome-wide association studies, so these are data sets that are prized for how large and representative they are. They, in fact, may have selection issues. In 2008, researchers found that 96% of participants of these data sets are of European descent. And the reason that that's so important, that it's really crucial to be able to have all the data represented, as we showed in examples earlier, but just to put it really clearly to the audience today, because different subpopulations have different data distributions, they have different conditional distributions, a decrease in sample size may in fact result in disparate treatment, disparate learnings, disparate clinical care. As one example, heart attacks present differently for men than for women. Men tend to have more of the cinematic clutching of your heart, and heart attacks may actually present as indigestion or back pain. And so you could imagine that not knowing about this may in fact make patients come and seek care later, and also clinical care may be delayed as well. So these have sort of downstream impacts on clinical care, as well as the data that we collect from this clinical healthcare system. All right, my animations are getting a little screwy. All right, so with a biased existing healthcare system creating biased data, is it any wonder then that algorithmic bias may occur along the way? My research lab focuses on ethical AI in medicine. I can't cover the whole pipeline in this talk. You can think about How are we choosing to pick the problems that we'd like to solve? How are we collecting the data in order to be able to represent everyone and collect the right features for the task at hand? How are we defining a task? What makes sense for the right labels? How are we developing this algorithm? Most people think that this is the meat of the whole project, but in fact, there's many other steps. And then lastly, how could we audit existing and deployed algorithms to ensure that they're not exacerbating existing health biases? So that's sort of my research in a nutshell. But today we're talking about something a little more current, a little bit more relevant. Questions of ethics have arisen for many, many years since before my PhD, especially in the cases of algorithmic bias. But today we're going to talk about large language models. As in this day and age, I don't have to ask if anyone's used large language model anymore. When I started giving these talks, I used to get a little poll going, but there have been many claims about the usefulness of large language models. For example, that they can solve medical challenge problems. They can score better than the median doctor on different medical examinations. They might be more empathetic based on some social media platform comparisons where you ask physicians to respond and you ask large language models to respond, and patients might find that the large language models are more empathetic in their responses, primarily because they're longer. And then lastly, there's this notion that an out-of-the-box model may in fact be more powerful than a specialized model that we've been working on, that we have these models that are more and more generalized that can still do quite well in medical context. So there's a question there of, do we need specifically clinical language models? Another side, but the sort of flip side of new innovation is that we have to be scrupulous that they're in fact improving the world and improving healthcare for all populations. So what do I mean by that? When we think about bias in large language models, we have a few different ways that researchers have already been trying to dig in and better understand what the extent of bias might be in large language models and how to define that, to be quite honest. For example, colleagues down at Stanford have looked at asking large language models what they call race-based medical questions. And so here you can see on the x-axis, these are questions that just say, how would I calculate the eGFR for different patients? Then clinicians went through and labeled whether or not their responses were considered concerning. So for each model was queried 5 times, and then each of those responses are rated concerning or not concerning. And you can see across the board, across many different models, for many of the race-based questions that were asked, there is a high amount of concerning responses from these models. To put it in more clinically relevant terms, another set of researchers, my colleagues at UCSF, looked at sort of patient vignettes and gave large language models, I believe in this case, GPT 3.5 or GPT-4, and they asked, is this patient exaggerating their pain? Is this patient lying about what's going on? Is this patient abusing narcotics or something? And in fact, found a heterogeneity in responses about whether or not patients might be lying about how much pain they're in themselves. This is sort of indicating that maybe the large language models have codified some of the existing mentalities about different patients, and in fact would be a danger of perpetuating that. The promise, though, and I alluded to this study earlier, is that physicians are really overburdened. Physicians do not have the time right now to be able to sit with each patient and be present and listen to all their concerns. And so to sort of to explore the potential for LLMs to be able to help physicians and help patients, the researchers looked at chatbot responses to medical questions versus physician responses. And in fact, human evaluators found that chatbot responses were more empathetic and longer compared to physician responses. So something like on average 211 words versus 52 words. And in fact, humans preferred the chatbot responses. Notably, this study did not examine accuracy of the response and also did not examine sort of what downstream clinical impact would be. But there's already starting to be some opportunity when we think about health equity and ways to serve underserved patients. All of a sudden, it's important to recognize the glass half full approach. So today I want to talk about 2 stories about large language models. not to spoil the whole thing, but one of them will think a little bit about more about the glass half empty, and then the other one can think a little bit about the glass half full and how large language models might fit onto both sides of this landscape. For the first project in maternal health, we asked the question simply, what do people want from large language models? How could we make sure that large language models are being used in the right way? How could we think about that? So this is an all-star team led by Maria, who just left AI2 and actually is at University of Copenhagen. So I need to update this slide. And specifically, we're looking at how to assess what's going on in maternal health and how we might develop principles for maternal health. Why maternal health? Maternal health is a perfect storm. It is the hotbed of a lot of existing natural language processing research, not just on clinical notes, but also on social media, on qualitative interviews with people already about how they go through the process and what their concerns are. It is a problem that affects the entire population. Everyone has been born at some point, and then many people might consider having children of their own. And it is also the hotbed of existing health disparities and worsening health inequities, as alluded to earlier in the presentation. And in fact, in this day and age, we find that maternal health disparities are getting worse. The year over year, we find that the deaths per 100,000 live births, for example, is getting worse for all groups, but also the gap is increasing between, say, Black mothers and white mothers, creating very concerning trends. We would love to be able to use large language models towards this. And so one of the things that we wanted to figure out how to use large language models towards this goal. And we determined that the best way to find out how large language models could help maternal health would be to ask the people. So we hosted a workshop with the American Association of Medical Colleges. And specifically, it was a maternal health equity workshop. And we said, hey, we're thinking of using large language models. If you were to use it, how would you use it? Can you tell us a little bit about that experience? We also wanted to make sure that we weren't just selecting people who attended a health equity workshop with the American Association of Medical Colleges. So we also used Prolific, which is an online platform for soliciting expert opinions and reaching a wider diversity of people. And we specifically queried for maternal health healthcare professionals and women in birthing people who have gone through that process. We didn't want to just ask them about their experiences and feelings. We wanted to put the technology in their hands. And so we wrote a wrapper around our GPT-4 API login, and we essentially said, hey, think of a time, here's what a large language model is, here's some training about what kind of questions to ask or how to ask it. And then we'd like you to just ask what you would have asked when you were a new mother or at a time when you as a healthcare professional have wanted help, or as a maternal health equity specialist, what might be things of your concern that you would use large language models for. And then we ask them after each response, like, does this seem like it's working? What are your thoughts about this tool, et cetera? And then lastly, at the end of the whole experience, we asked about their overall thoughts and values that would matter to them. So let's start with the very end. We asked across 11 different ethical values that have been determined for figuring out how different groups might prioritize different principles for responsible AI. And so across our three populations, the workshop participants, the healthcare workers, and the birthing people, we have a few different findings. Because the font is small, I'll just blow it up and make it super obvious here. First of all, birthing people, so these are patients, individuals going through the birthing process or have gone through the birthing process. Number one priority they wanted was privacy and autonomy. So they wanted to know that their data wasn't going to be leaked, that even though they're talking to someone, that data is not going to fall out and accidentally end up in someone else's model or in someone else's responses. And then similarly, they wanted to know that they ultimately had autonomy, that if they said, I don't want to follow that recommendation, they didn't have to. And also that they would be able to see a human if they wanted to. So they would be able to say, I don't want to talk to a robot. I'm done. I would like to see a clinician now. Healthcare workers, sort of on the other side of the medical examining room, healthcare workers seem to prioritize transparency and accountability. So here we found that a lot of the healthcare workers were concerned about what's going in these models. What is the data? Has it been trained on medical data? How well does it work? How does it work? What is it? Why is it giving this particular recommendation? And then on the accountability side, a lot of the concerns revolved around if I follow this model, if I trust that this model is going to work, who's going to get in trouble? Who's going to be held accountable if it doesn't work? How can we design a system where I don't feel like I have to check every single thing that it says? I don't have to be constantly suspicious while also being not blamed if things go well or not well. And then lastly, our workshop participants. So these are our health equity folks. They obviously all 11 values are important to all of the people, but I think one of the things that stuck out was that inclusiveness was really important to the workshop participants. So in the concept of health equity, it was really important to these participants that we had a lot of people involved in the process and that we solicited a lot of values along the way. This was my first experience in a user study setting, and I found it to be actually quite thrilling to be able to start to see how the real users might use large language models through and what their concerns might be. One of the best parts actually was filtering through all the qualitative research. So when given free form response time or asked more generally about what they were thinking about large language models, I was surprised that the vast majority of people who responded in our study actually were quite optimistic about large language models. One clinician or one patient talked about how it would have been great to have a tool like this when their son was a newborn and how they didn't want to feel alone. They wanted someone to interact with, someone to talk to at 2 a.m. It would have been nice to have a tool like this. Another person mentioned not wanting a resource when they wanted quick answers. It seemed like a thing that would be really helpful to them. In fact, instead of, piling into a car and driving to a doctor's office and waiting and trying to figure out when the available slots would be, if you have a quick answer, if you just want to check what's going on, it's nice to have a resource like that. And then the last person that I want to highlight mentioned that it would be really nice to empower those who are lacking social and financial support, that this large language model could be a way of shifting power, shifting people who are sort of most in control to people who are lacking resources and would be able to tap into that through the large language models. Although all the people were quite optimistic, people were perhaps rightfully concerned about the existing healthcare system. That if you plug it into the existing healthcare system, they did not see a ton of evidence that it might go off smoothly without any hiccups. One participant raised the point that they didn't want nurses and doulas to be replaced. They didn't want nurses and doulas to see fewer people seeking care. They didn't want to be mothers to rely too heavily on AI and cut out these other maternal health professionals who have been vital parts of the ecosystem. Then the second one I think is pretty funny is that, the insurance companies think there's cost savings. Maybe the healthcare system will try to incentivize people to use AI in order to cut savings. And in fact, the individuals would suffer, the patients would have a worse experience as a result. And the last thing I want to sort of highlight, the last theme that came up time and time again, was that people had guidance for the large language model developers. They said, we want to know where the sourcing of the data is. We want to have transparency there. And we want the AI to actually provide solutions. We don't want, quite frankly, we don't want you, the people running this study, to just say, oh, we know that there's problems. Like, how are they actually going to solve this? How could we go about in making sure that these problems will get fixed? So in collaboration with the American Association of Medical Colleges, we distilled all of the surveys, all of the interviews we did into 9 principles. I'm not going to go through all of them, although you're welcome to look up the paper, and I think it is quite fun to sort of dig through and see all the ways. And then they made these great animations for us, which was also a first for me. But I think principles including learning from maternal health traditions and communities, as well as centering and including the voices of birthing people, come straight out of the study results and figuring out ways that for maternal health equity especially, we can make sure that we are on the right track, especially as the technology continues to develop. So as a sort of recap for this particular section, I want to emphasize that people had complex hopes and fears about large language models. One of the things that we really found helpful in the survey was that giving people direct access to the large language models really crystallized what they were to these participants and also allowed us to better understand what exactly they would use these large language models for. This paper that we published in FACT this year described mainly the surveys and the interviews that came out of this process, but we're actually working on some follow-up work that looked at the queries themselves and how we might determine if people did or did not succeed. Did they get their answers solved? What kinds of questions were they asking? How did they feel when the large language model came back with, I'm not a doctor, but, and what is sort of that relationship between large language model and healthcare participant, patient, professional, et cetera, and how might we characterize that relationship? I also want to emphasize here that different populations may have different priorities. We see that time and time again that healthcare workers and healthcare patients have slightly different hopes and dreams for large language models. And I want to also emphasize that this is an ongoing conversation. So we did GPT-4. I'm sure, different models. What if we used images as well as text? What if we had it talk in the style of Oprah? Like there's many different ways that we could have iterated these experiments, and they will continue to evolve as the technology improves. All right, turning towards the second half of the talk, in addition to asking what do the people want from the large language models, we wanted to look into the clinical setting itself and think about how large language models could improve the existing clinical workflow. This is led by the amazing Brenda Miao, who just graduated from UCSF, as well as a large and very talented team who sort of came together to be able to make this project happen. AI is increasingly being used for clinical decision-making. So researchers might rely on things like causal inference to compare a treated and control population to estimate how, for example, a medication might impact blood pressure. Tools like reinforcement learning might also aim to solve sequential decision-making. And we think about both of these, it relies on the fact that we understand which treatments are given and why patients might not choose to take that treatment or might choose to switch the medication as a result. What do I mean by that? We often want to learn from longitudinal observational data. The electronic health records are a great example, and they're readily available in many hospitals. So researchers generally have access to electronic health records. For example, we have 3 patients here with one biomarker collected at different times for the 3 different patients. And in fact, we would like to see how different treatments are affecting these patients and what treatments we should give to a patient D, a new patient, based on the prior patients and how they've responded to the treatments that were given. Treatment plans may vary. For example, here, all 3 patients get treatment 1, but patient B and patient C don't seem like they stick on patient 1. Something happens and they end up switching to a different treatment. Maybe they switch to treatment 2, maybe they switch into treatment 3, but something happens, and it would be nice, instead of just learning the biomarkers, to be able to incorporate the clinical interventions as well. So the big question here is why? Why did this patient switch between classes of medications? They didn't leave the healthcare system. It's not like we still have data on them, but we'd like to be able to understand, was it the fact that the disease progressed? Was it the fact that there were adverse events? Was there a patient preference? Was there a socioeconomic factor? What's going on? Fortunately or unfortunately, that information is available, but it is often sort of locked away in clinical notes, which are unstructured and quite hard to reason about, is with traditional machine learning techniques, traditional natural language processing techniques. But this is a large language model talk. We are here to better understand how we might use large language models to understand treatment switching. The example that I'm going to use today is about contraceptives. We chose contraceptives to start in this project for a few reasons. One, they're widely available. About 65% of all women in the US ages 15 to 49 are on a contraceptive. So that's about 50 million women. And people switch contraceptives a lot. 44% will discontinue contraceptive use within the first year. And of those people, 76% will actually resume on a potentially different contraceptive within 6 months. So there's a lot sort of at play about how to understand what's going on, and there's a lot of zigging and zagging, so to speak, between contraceptives. There is actually a lot of research also between conducting interviews, as well as scraping social media data to figure out why people choose different contraceptives and why they might switch it. So our research question then is why? Why are people switching contraceptives? Can we start to categorize how that might be different across different patients? Our workflow is roughly we identified different clinical notes between different patients. You leveraged a large language model to extract both the treatment strategy. So just this is basically confirming the structure data that we did have access to as well. So like what was the current treatment? What did they switch from? What did they switch to? Was there a switch? And then we also extracted from the clinical notes the reasons for the switching. What is from the notes, what seems to be going on? The first thing we did was we evaluated. So we sanity checked. Does this large language model seem to know what it's doing? So that's this left-hand side. And then we started to look at unsupervised clustering on the right-hand side of better understanding general trends for these reasons. So we use the UCSF Information Commons. This has been a tremendous resource of over 5 million patients, over 135 encounters, and it stretches back years and years, all the way back to the 80s, although not every patient was logged in the 80s. It's like 5 patients were logged in the 80s, and somehow we still have that data. So it does technically go back decades. At UCSF, we also are fortunate to have a HIPAA-compliant Microsoft Azure API, meaning that we can use resources like GPT-4 without the clinical data ever leaving the server. So I want to emphasize that we are completely compliant with the IRB, and we're very careful that no data is being sent back to companies that do not have the right to see that patient data. So the first thing we did to check, does this pipeline seem to be working? Are these extracted reasons and the treatments, are they correct? Is this something we could be even feasibly doing correctly? So the first thing we did was we got 5% of the data and we asked clinicians to hand label if the LLM was correct. And we found about almost 92% of all of the stopping rationales, all the switching explanations were in fact correct. So that's great. We also asked about hallucinations. So there's something quite scary if the large language model is just making stuff up. It might be misunderstanding some notes because of abbreviations or turns of phrases that are quite tricky to grasp. But it'd be another thing if it just made up completely wrong things that weren't even in the medical record. So thankfully, when we asked clinicians to grade these large language models specifically on hallucinations, we found that about 2% of the explanations were hallucinated. So still not 100%, but still some pretty reliable, at least in aggregate. The other thing we checked is that we asked large language model to extract things like which medication did they start, which medication did they stop. And the idea behind that was to determine, and we compared it with the structured data. The idea behind that was to see, okay, for something that we could systematically, automatedly, in an automatic fashion confirm, did the model seem to outperform that? And we found here GPT-4, yeah, it seems like the zero-shot case here does outperform many traditional machine learning baselines, including a BERT model that we trained also on the UCSF, or we had fine-tuned on the UCSF notes themselves. So for a zero-shot case, so 0% of the data all the way to 100% of the data, does seem to be outperforming many supervised learning models. Next, we were interested in the topics that were learned. So here we have a variety of different topics. So just going through them, some of them are related to patient symptoms, for example, irregular bleeding, irritation and rash, topic 4, irregular menses, topic 7. Others are related to patient preference. We could take a look at topic 2 and topic 3. Topic 2 is just about if the patient has expressed preference in a specific class of contraceptives, and topic 3 is about how hard it is to remember daily pills and patients not wanting to deal with that. But something that came up that I want to sort of turn our attention to is that topic 8 was related to insurance. And so of the 9 topics, where the number of topics was chosen dynamically by the algorithm, by this HDB scan clustering algorithm. In fact, one of them was related to, you could say, socioeconomic status questions and figuring out how that would affect their care. So the next step from here was to see, do these topics affect all of the patients equally? So our first sort of proof of concept would be to stratify these patients by age. So on the y-axis, we have age groups. We have less than 21, 21 to 30, 31 to 40, 40 plus. And across these 9 different topics, we found that there are differences in how the different groups responded to the topic. So just to zoom in on three, we see that, for example, topic three, forgetting daily pills, is something that the below 21 crowd, the sort of evidenced by this hot red color, were much more likely to forget their daily pills than, for example, the 40 plus people. And then similarly, insurance coverage, which I just mentioned, was also something that younger patients were more worried about compared to older patients. Topic five, this is something that was quite interesting, is that the malpositioning of the IUD was also something that seemed to be positively correlated with age, meaning that it became more of a problem later on compared to earlier. But that might also be confounded by the rates of IUD usage, which I'll talk about later. So the other thing that we looked at was because we're interested inherently in health equity and how different groups are being assessed, we looked at stratifying by race as well. And here we found that this insurance coverage topic predominantly affected Latinx, Black, and multi-race groups as well. And so all of a sudden, we started this discussion thinking about clinical decision making. How can AI affect it? I think topic switching, treatment switching, and why patients don't like their medication, we often assume that it will be all of these other topics that'll be related to medical things, it'll be related to clinical factors that we can measure. But I want to sort of pose the question to the group that we might be able to use some of these advanced tools like large language models to be able to explain different clinical decisions and explain the heterogeneity across the patients that could be useful for to have important implications for clinical care. So I would say our findings show that you can use large language models to explain clinical decisions or treatment switching specifically. And we're interested in patterns in long-term outcomes. We could, for example, use this to study different patient cohorts or improve the cohorts for prediction problems. And we'd also like to disentangle this complicated picture of patient health, which could be quite important. I'm coming up at the end of my time. So I think the last thing I want to sort of touch on and pose to the group is there's this question of if algorithms were used more in medicine, they phrase it in a really weird way, but it's biased and unfair treatment based on patients' race and ethnicity. So you can think of this as racial bias in medicine would get better, stay about the same, or get worse if AI in medicine were used more. And so it's hard. I know there's 47 people on the call right now, but unfortunately, I'm just staring at a picture of my face. So I'm not going to make you guys poll or something, but I want you to think in your head. I know there's a bunch of caveats. I know, how are we defining AI? How are we defining race? How are we defining all this stuff? Just in your head, think of if your gut is to go with get better, stay about the same, or get worse, and how you think though that your answer, what do you think your answer would be and why among these three very, simplistic answers. So I'm going to give you a few seconds to think on that. All right. It turns out that in February 2023, they polled hundreds of, I think tens of thousands of people to see how they would feel about this specific question. And it turns out the answers were, I would say, mixed. The truth is, when I think about this answer, my answer changes almost daily. So part of me really wants to be optimistic. Part of me says, oh, yeah, the AI could rely on clinical features. The AI could objectively look at data and not assume anything about patients. It could just analyze the data as is described by someone here. But on the other hand, the data is actually created by humans, right? It relies on existing clinical practice. And it turns out humans are quite biased. And so maybe it would stay about the same. So it's sort of garbage in, garbage out, mildly interesting garbage in, mildly interesting garbage out. Maybe in fact, it would be gray. It would stay about the same. And then lastly, 15%, the way that AI is deployed, the way that we have such blind trust in large language models or other AI tools could be quite dangerous. And in fact, you could be removing human judgment out of the process, which might have been saving us this whole time. And so in fact, it might make racial bias in medicine worse. So my charge to everyone today would be to think, could it be all three of these? And what would it take for AI in health to actually improve racial bias? What would it take to be able to understand all of the potential bias that is being exacerbated and understand the status quo that's being perpetuated, but also move the needle and actually improve questions like health equity and racial bias. So today I've talked through two specific examples of how we might think about large language models, bias, and health equity. Um, if there's sort of three things I'd like you to take away from it, it would be one, that we want to model all heterogeneity. So how can we design studies that engage with the realities of patients or algorithmic deployment? There's a long tail of situations. How do we model that? Second is that always, always, always people over algorithms. This is easy for me to say as a computer scientist who sits in front of code all day, but it's important, or maybe paradoxical for me to say as a computer scientist. But ultimately, large language models and other AI tools are meant to be helping healthcare. But who might be helping? Who might they be hurting? How can we think again about this heterogeneity of the long tail of patients who might be getting affected? And the third is that we are in a new age of models. We are in a new age of data access. Never before have we had such um, computational advances under our belt and data sets at our fingertips. How can we think about guidelines in this new paradigm? What has been working, what hasn't been working, and how might that go ahead and be changed? So I'll go ahead and pause there and open up for questions. But thank you so much for your attention.
Thank you so much. We already have one question, so Vishal, please go ahead and ask.
Yeah, hi. Thanks, Irene, and thanks, Alethea. So, Irene, this was a really nice talk. I have two questions. One related to part one of your talk, where you spoke about the direct interaction study. I'm curious. I'm especially interested in this because it sounds like you used prolific. In the past, when I've used prolific, I don't know how you selected for healthcare workers, but that's very interesting if you were able to do that. And then and when you chose the birthing people, like do you have any data right now about how many turns they went on with in their interaction with ChatGPT, given that it was a direct interaction? Like, was it multi turns? Did they and did you have a specific question that you asked them each turn they went to learn about their satisfaction? Or what happens, like you explained, when, say, the model comes back with, I'm not a doctor or I'm not a healthcare professional? That's my first question. The second question was that I did go to sales, so I heard Brenda talk about the
Ah,
part of the study, but so it was really interesting to revisit it. And this time, one thing that came to mind was, I know the data set that you used was like, it's amazing that UCSF has that, but would it help to supplement it with my chart messages? Just because I think that sometimes in the notes, maybe there is not that documentation of why a switch was made. Did you have that issue at all, or of the missing information? And would it help in that case to supplement with my chart messages? And it was nice to see your topic modeling of like top topics of like what got covered. Would it also help to use social media data to talk about to expand or to sort of like enrich the topics? Sorry, it was a long question, but that's it.
absolutely. So let's see if we can parse that through. So first was about using Prolific to supplement our American Association of Medical College workshop participants. So you're right, Prolific, querying Prolific, getting people on Prolific is not an easy feat. We found after extensive recruiting on sort of keeping it open for a while and being very specific in our instructions and our filtering, that we were able to get on the order of a few hundred healthcare professionals and women and birthing people. And that was sort of in the selection criteria on the Prolific platform. The way that we got people to interact with the large language model was to specify that you have to ask 5 questions. You have to go back and forth 5 times. You could follow up on what they said. You could continue the conversation. You could ask something else, but we want five something from you. And so that was a way of ensuring that they would engage with it, even if perhaps they would be frustrated at the model for giving the wrong answer or deferring or something like that. We at least wanted some interactions there.
No, thank you.
Um,
That really helps because so there was mandated 5 turns.
5 turns at least. They
Okay.
could do whatever they wanted, but at least five. And
Okay.
so now we have this rich data set of, several hundred people times five, which has been quite nice. And it's ongoing work right now to investigate what 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 we could possibly find there. I wanted to respond to your second point about contraceptives, specifically what kind of data we're looking at, what we could supplement with it, et cetera. So we did look at primarily exclusively the electronic health record. So these are all the clinical notes. We did not include my chart messages in between doctors and patients. At the UCSF, that's actually stored in a separate database. And so we chose to start with the electronic health record for this preliminary study. We also were very aware that there's a huge body of work looking at interviews and social media data to better understand contraceptive switching, as is specified on this slide. Because of the way that the model was set up and also the research question we wanted to ask, the way I framed the original thing, which is that we already do clinical decision making analysis from electronic health records using AI. Like this is a well-trodden field for people right now. We were curious about whether or not adding nuance about why people were switching treatments, and whether or not there are ones or reasons that are non-clinical, that actually would only be available in the clinical notes, and whether or not unlocking that using large language models would be helpful and perhaps disproportionately helpful for different patients, different subpopulations. And that was sort of our motivating factor here, which is that we wanted to see how in this landscape of clinical decision making, how treatment switching rationales might be helpful. So if we wanted to study, I don't know where the slide went. Yeah, there it is. To study contraceptives in general, absolutely, we should be looking at social media data. We should be looking at different topics that are learned. We should figure out, given the selection bias of electronic health records, how can we better understand the entire landscape of contraceptives? And I think that would be a really interesting study. Our aim for this study was to be able to determine how existing electronic health record AI tools might be overlooking some reasons about why people switch medications. Does that help provide some clarity there?
Yeah, that definitely helps. Yeah, no, thank you. It was a great talk. So yeah, thank you.
Great. I'm glad you enjoyed it. I'm just scrolling through the chat and I see that Tatiana has asked a question. Do you want to unmute Tatiana, or do you want me to just read it out loud? If you don't say anything, I'll just read it out loud.
Hi, I can speak. Can you hear me?
Yes, I can hear you.
Awesome. Well, thank you for the excellent talk. I really enjoyed this topic about healthcare equity. I'm really curious about what other sorts of data insights or data was in the research findings. And one of that is if lifestyle and geographic location play a role in the research insights, meaning maybe my lifestyle changes throughout my life. I become more active, less active. Therefore, I choose to use a different contraceptive that fits my uh, new life.
Oh yeah, that's absolutely a great question. And I think we were specifically looking at moving from one contraceptive to another. But you could imagine, if people decide that they want children, for example, that they could stop taking a contraceptive. And that would be a very clear example of a lifestyle change. When we looked at the treatment switching reasons, lifestyle as manifested by uh, let me think about the right way to phrase this. I guess you could see lifestyle changes in many of the topics described. For example, not wanting to remember a daily pill is a lifestyle choice that you want to be able to, switch time zones very easily or something like that. As well as thinking about patient preference is sort of a big one that becomes an umbrella for many different things we found when we dug in there. And then yeah, I would say those two probably most fit in with the idea of lifestyle. If we wanted to test specific hypotheses about, for example, how age changes, that was why we stratified by age to see if there were different factors that affect you at different times of your life, to be quite honest. And maybe people who might be having children in the near future would want more flexibility than people who want kids in, in 5 to 10 years or something like that. And so I think that's also something we were sort of aware of. I saw in your Zoom question that there was a question about geographic factors. Because we looked at UCSF, all of our patients are from the sort of greater Bay Area. People do drive in from further away, but ultimately it is based off of one hospital, and I want to make that clear as well.
Great. Thank you so much. That's awesome to hear.
I see another question by Akyaz. Do you want to unmute, or I can just read out the question out loud? I don't mean to put anyone on the spot.
No problem at all. Great talk, by the way. I have only a small note and question regarding the influence of insurance in the court. As you stated that this court is coming from the Bay Area, and I have the impression this will be more related to the income rather than the insurance itself.
Yeah, I think that there's so one of the things that we wanted to sort of emphasize here is that there are many, many factors, as you can imagine, that are not captured in the clinical notes that might be related. One thing we wanted to look at was marital status, for example. So maybe there's something about how people choose to go on or off different contraceptives based on that. Unfortunately, in the data cohort that we had, marital status was not a factor we could measure. Education status was also not a factor. The way UCSF allows access to the data, if we wanted something like zip code, we would have to file an IRB, which we're in the process of doing. And then we could start to maybe stratify by income or other environmental factors or something like that, that could give a little bit more insight into things that are not purely in the clinical notes as they exist. So that's an excellent point, and I think it would be or past behavior, past clinical history. That was something we also wanted to dig in as well. Maybe people have different concerns or different hormonal issues that would make certain contraceptives more difficult and less likely than other contraceptives. And so I think all of that feeds into, as you can imagine, a mosaic of patient narratives and patient history that would be important to better understand, to be able to conclusively say, like, that's why this person switched from this medication to that medication.
Sounds good to go. Really thankful. Thank you so much.
All right. Any other questions? I know that there were a ton that were sent in advance. I don't know if we want to transition to that or if we want to, play around a little bit more.
Yeah, if anybody has question, I see one more. Is there another one in chat? No. I can quickly look at some questions that were sent before the presentation to see if you want to tackle some of those.
Sure, hit me. Let's do it.
That's good. Okay, let's do it. Just pulling up that I had that email up and then sorry. Okay, so so the first question is like detecting and identifying bias. How can we implement governance model to mitigate these biases in institutions? Like any recommendations on what institutions should be doing?
It's a great question. When I was, a young PhD student and perhaps a little bit more idealistic, I thought the FDA is the regulatory body that looks at algorithms used in healthcare. They should be regulating that. That's how we should enact change. In my personal opinion, does not represent views of Berkeley or UCSF or anyone. It does seem like regulatory, like official policies might be a bit lagging. And in fact, we find that clinicians and researchers regulate ourselves. And so I think one of the ways that we have learned to get people to think about these questions of bias and equity more comprehensively earlier in the pipeline, as I described it, all of that is by doing advocacy work. So that's going out and auditing algorithms that are out there. That means sharing the findings that we find that we see in our analysis. It means engaging with people when they ask, what's the point here? This isn't illegal. It isn't, this algorithm is really good for this population. Maybe it's not good for another population, but we do want to improve clinical care and we do want to improve outcomes. And so I think it is a tricky question. If I knew, maybe I would be running the FDA myself, probably not. But ultimately, I would say it requires a fair amount of vigilance from the research community and tooling to enable people to do their own analysis if they would like.
Yeah, thank you. And any recommendations or thoughts on how should people be thinking about LLMs that are more focused towards patients versus LLMs that are more focused towards providers?
It's a good question. Right now, we're really in the Wild West. I mean,
Hmm.
I'll confess that I use LLMs for health issues all the time. I drop something on my foot still hurt a few hours later. I messaged an LLM and I said, am I dying? Should I go, or not even so dramatically, but should I go through the process of making a doctor's appointment and going in and seeing if something is working? Like what, I really relate to that person from the study I presented who said, I just want a quick answer. I don't want to have to go and deal with all of this. So I think there's tremendous potential for LLMs to help patients. There is some question, though, that maybe if the question becomes too serious, the LLM should be able to say, like, this is beyond my scope, or this, I could answer this, but I have been instructed not to, or this is something that we as a medical community have decided is not something that you, a patient, and me, an LLM should be discussing. It should be a human involved as well. And so I think all of those are important factors to think about. As far as large language models for clinicians, I'm very empathetic to the fact that clinicians are completely overworked right now. Their burnout rate in clinicians is immense. The amount of time charting and writing notes and reading over other people's notes and not talking to a patient at all is about 50% of clinician time is the last study I saw. And so the electronic health record has really been a boon to researchers like myself who have a lot more access to data, but it has not been helpful so far to clinicians. And they spend all this time generating the data, but they don't really see the benefits necessarily from the EHR data. And so I am actually incredibly concerned about how we might improve clinician workflow, clinician burnout rates, clinician ease of use, and to do it in a way that does not hurt clinical care and is a way that is not biased. So I think all of those factors come into play, and it's a hard thing. I see that Lily has asked, are you aware of documentation capture and analysis for physicians, clinicians using only telemedicine? There's a series of studies coming out of Microsoft using it's not Dragonfly. The name is escaping me right now, but there's a whole initiative to be able to like have two people just talking to each other and then an AI capture the whatchamacallit, the notes and then not have the clinician not have to deal with it. My understanding is that those results are pretty early. And so we would like it to work. It's quite possible you'll still need a human to read over at the end and just sign off or something like that. But we are on our way. I'll say that.
Thank you.
Awesome. Thank you so much for the great presentation. And thank you, everybody, for great discussion as well. We will post the recordings in the next coming weeks on our Healthcare Partnership website and also share the deck if possible. And then thank you so much for attending the event. And please sign up for future events too. We've just posted the link.
All right. Thank you, everyone. It was lovely chatting and great questions.
Bye.
Thank you.